John, let me ask a perspective question. I think Molina Healthcare has elevated its position amongst the pantheon of health plans, particularly in the last decade, and particularly after the implementation of the Affordable Care Act. We had a dinner last night with some folks, and I said, as I said here, that Molina has also elevated its profile in terms of speaking out in support of the Affordable Care Act, really with no other comparable health plan voice speaking as candidly and as actively. One of the participants, and I asked this table last night why that might be the case, and one of the speakers who happened to be with a health plan said it was because other health plans were craven, was his word. I was shocked, candidly. I thought that came from somebody else, but it wasn't. I thought that represented a real candid comment about where the other health plans are on this. Did the health insurance industry let itself down by not more actively advocating for the ACA since its passage in 2010? So now we're at a point where we're kind of playing defense for those that see it as progressive?
I think that a significant number of health insurers are afraid of the bully pulpit. And in this case, the emphasis is on bully, and it comes through a tweet. At Molina, my brother has really taken the lead on health policy, and he's not afraid. The ACA is a tremendous first step, but let's face it, it did not accomplish the goal to make things more affordable, and did not do anything to the supply of providers. Those were the two other things that I think needed to have happened, and given the bloody fights that went on after the passage and the way it was passed, no one else wanted to touch those other things, and now it's come back, I think, to hurt us. Fundamentally, it is the ACA's insurance reform. And what we need to do is move from the financing to the actual delivery of health care. And once Congress either does something to change the ACA or tries and fails, maybe we can put that to bed and focus on things that really affect patients. Like, do I have a doctor I can go to? What is my deductible? Do I understand my benefits? I ask people all the time, have you looked at your healthcare policy that you get through your work, and do you understand all the ins and outs? And most people don't. And yet through the ACA, we did the greatest expansion for people who are at the lower income of the economic spectrum. And folks who are poor tend not to be as highly educated as the folks in this room, and yet we're saddling them with tremendous burdens as a consumer of healthcare. So we need to move beyond the rhetoric, beyond the politics, to actually start talking about how can we improve the system, not just how do we pay for it. Mm-hmm. Now, paying for it is really, really important. I'm not trying to minimize that. But in terms of what we need to do as a country, we need to get beyond that.
How do we, I think many folks, John, would agree with you that the Affordable Care Act was largely an insurance bill, that of the three North Stars towards which health policy might be oriented, either cost, quality, or access and coverage, and I merged those two, I know they're different, but I merged those two, that this was a bill largely focused on coverage and access. How do we get to a reorientation, or should we, away from access and coverage to cost or quality? Is it possible to do two of those three things? If I sort of, there's this, it's hard to do all three, but can we do two? And if we can only do one, are we still oriented towards the right North Star, or is it time to change?
Well, I think you have to, step one, you've got to get everyone some sort of coverage. We can't have people who are faced with bankruptcy because they get sick, We can't have people who have illusory coverage where it is basically the deductible is so high, the copayments are so high, they just have catastrophic coverage. So we've got to get the financing in place. Then we have to work on access. We are going to run into very, very shortly not enough providers. And nothing that I can see is being done to address that. There are the same number of residency slots now that there were probably 10, 20 years ago. That has to increase. We have to figure out how to use mid-level practitioners. We have to extend out and figure out how do we engage pharmacists, optometrists, home care workers in the healthcare continuum. Because as the population ages and consumes more healthcare services, just by the nature of their aging, without having more providers, we are going to have a system of haves and have-nots.
As the CFO at Molina, let me ask kind of a question that I think the answer is probably both, but let me just sort of pose this and see if you can parse it out for me. As you think about the numbers at Molina and in terms of costs, Ken is talking about the importance of focusing on prevention and utilization management effectively and care coordination. I think HMOs, I think Medicaid plans have demonstrated much greater success at that empirically than some PPO commercial plans. When it comes to policy, should policy help support that aspect, utilization management, primary care, like I think the ACA does in part, or should it focus on broken economic markets? In other words, cost and price is still a major factor where there is market consolidation and market leverage, and there are no other large hospital systems or no other drugs to replace the Hep C diagnosis, or few drugs, or where plans and the payers effectively have little purchasing power or ability to affect the market. That is a policy area which the ACA does not address. Should this next round of federal policy discussion be more focused maybe on the primary care prevention and utilization management, or should it be a little more focused on fixing broken economics in healthcare?
I don't think you can have one without the other. One of the things that's very interesting, the discussion on higher disease burden and more prevalence of chronic diseases really does get back to the financing of care. And here's the thing that is just the disconnect. We're trying to provide financing and payment models that pay for quality. Unfortunately, for Medicaid and Medicare, the payment systems, the way that rates and premiums are calculated, it is 100% based on fee-for-service data. So you can have a health plan, you can have providers that save a lot of money by providing very high quality care. They're not economically incented. In fact, from a health plan standpoint, you're probably incented to generate more costs because you can throw on top of that a margin for profit and administration, et cetera. And it's almost gotten to the point where, in many aspects, healthcare financing is almost like a regulated utility back in the old days. So we have to figure out how providers can legitimately be reimbursed and paid for quality, how the risk transfer or risk adjustments based on the acuity of the members is calculated. Interesting thing is right now, under the ACA, we transfer approximately 25% of our premiums, which in 2017 will start at about $4 billion. So we're going to transfer $1 billion to our competitors because theoretically they have sicker members than we do. But what's taken into account is not the acuity of the members, but it's how high the premium is. So you've got all of these issues that go against the policy of providing high quality, comprehensive care. In terms of the system delivery, I think we're going to be driven more and more to integrated delivery systems like a Kaiser, a Geisinger, a Cleveland Clinic, or for those providers who want to remain independent, we've got to create tight networks of virtually integrated delivery systems. Because if you look at the outcomes of those types of delivery systems, they tend to be better than wide dispersed groups of independent 2 and 3 doctor practices who are loosely affiliated with hospitals.
I got to tell you, I do think Molina has demonstrated not just its sort of confidence and courage of its convictions, but I think has been way out in front on trying to have a proactive care coordination strategy for its sickest members, to use data in thoughtful ways.
Thank you.
Well, thank you for doing it. But yet, when I listen to some of the SEC calls from providers that are publicly traded, I hear about providers saying we need to drive up our fee-for-service revenue in order to meet performance. This clinically integrated network, or excuse me, an increasingly integrated provider plan framework, I guess I'm wondering, do you see the providers at Molina that are employed by Molina, the primary care providers, is that a strategic advantage for Molina as a health plan? And is that something that you think probably should be built out more broadly as we move into this next phase of reform?
We do see it as a strategic advantage. It's much easier for a provider to be able to focus on, in our case, a single payer, and understand the rules and the requirements, as opposed to trying to figure out how to manage through 15, 16, 17 different sets of rules, because that's what they have to do in order to keep their practice open outside of an integrated system. So we are going to expand, but we're also expanding our definition of a provider. If you look at patients who are covered both by Medicaid and Medicare, the dual eligibles, people who have 5 or 6 conditions, an awful lot of their care isn't medical per se. We provide an awful lot of services for people to stay in their homes. So we have to make sure that they have food, that their homes are clean, that they can bathe and dress. These are social services, not medical services, but done right, it keeps people out of a nursing home and saves a lot of money. So now, the provider that people see on a daily basis may not be their primary care doctor, may not be their specialist, it may be the person who comes to their home for 3 or 4 hours a day that helps them maneuver through the day and keeps them healthy. I think the other thing that was mentioned earlier is the question about data and healthcare, and why haven't the technology companies sort of got it yet? In healthcare, but they have it in a place like banking. Think of banking. There's a finite set of services. Everybody understands what a deposit means. Everybody understands what a bank balance is. Everybody understands what an ATM machine is. Healthcare is much, much different for a 9-year-old boy than a 90-year-old woman. But we sort of lump everything together and say, that's healthcare.
Yeah. At the risk of, I just want to make sure I put a really fine point on this, because at the risk of sounding gratuitous, because I'm not trying to be, but I think that there's safety in numbers, and yet there were not a lot of people, not a lot of organizations out advocating for the ACA. I think that the House Republicans have voted 60 plus times to repeal the ACA, yet now I think there's common acceptance as a result of advocacy efforts like Molina's and others that things like the pre-existing guaranteed issue ought to stay. I think that's generally accepted now by all parties in DC. Yet, let's say the current AHCA passes, despite whatever efforts might be made. What is so wrong? If I'm a Republican member of Congress, what is so wrong with saying a state like California, the Medi-Cal system, ought to be able to live within a fixed trend line? we're going to give you a 3% growth every year, maybe fix that to population, so as population grows, you can also grow. That's a central element of the bill, that there's some per capita cap or some block grant cap in Medicaid. Advocates have said, supporters, progressive advocates have said that's not acceptable because that would ultimately take money out of the system. But if I'm a fiscal conservative, it seems like the healthcare system, the largest part of our economy, ought to be able to figure out how to live within the rate of inflation. What do you say to that?
I think it sounds theoretically nice until you get to the next recession, and your block grant, which was based on unemployment of X, and unemployment goes up to X plus 50%. I think that, excuse me, it doesn't hold necessarily. It might work if you pick the right rate of inflation, but they don't. And so the gap between what is needed and what is available is going to get too large. It's going to get larger over time. Mm-hmm. Because again, fundamentally, it's based on a fee-for-service mentality, where providers all along the spectrum have an incentive to do more. And changing that mentality can be difficult. When you go to your lawyer, unless it's on a contingency fee, the more the attorney bills, the more you pay them. They've got an incentive. When you go to your plumber, the more the plumber does for you, the more you're going to pay him. And so now we're asking an entire healthcare system to say it's not about how much you do, it's about what the results are. Now that's the right way to go, but it's going to take people a while to get there. I also think that there are other ways to accomplish savings, bending the cost curve, et cetera, that don't involve per capita spends or block grants. And I think that, as was discussed earlier, the way you do it is you don't start the discussion based on the financing. You start the discussion based on what healthcare we're trying to achieve and work back from there. Anytime you put the financing first, you box yourself in.
Last word, advice?
I would say don't be afraid to experiment and don't be afraid to speak up. The folks in this room know more about healthcare policy than any congressperson, any congressional staffer, anybody in Sacramento. Don't let them define the dialogue. Healthcare is too important.
Let's give them a round of applause.